In terms of resistance here, we know that ibrutinib resistance is mainly driven by BTK mutations. You can have the PLC gamma 2 mutation that's downstream for that as well, although not as common. Is this the same thing for acalabrutinib?
Right. The Ohio State group has recently reported at ASH last year that they did detect the same type of resistance mutations in patients on acalabrutinib as on ibrutinib at a median of about 33 months on therapy. This is mostly in the relapse setting. And there was about a 1-year lag between when they detected them to when the patients progressed. Now, they did raise the possibility that they were detecting these mutations a little bit earlier in patients who'd switched from ibrutinib to acalabrutinib. We don't really have long-term data about whether holds in the setting of problems and then switching to acalabrutinib might contribute to resistance. The patient numbers are very small, so it's hard to tell. But part of the reason I lean toward acalabrutinib first is because I think that overall it's probably better for the patient not to get a serious toxicity in the first place, which in my experience has been much less with acalabrutinib than it is to let them get it and then hope it goes away when you switch to a related drug in the class.
Yeah, I completely agree with that. That's why I've been favoring acalabrutinib as well. So, you know,
we have new generation non-covalent BTK inhibitors that are targeting the CYS481 mutation. And in particular, 2 of them had very nice looking data in terms of responses at ASH. The ARCule drug and then also the Loxo drug are looking quite promising in patients who have these mutations. The non-covalent drugs are able to inhibit the mutation as well as wild type.
Yeah, and then from the phase 1 data, at least from Loxo, it looked like the toxicity profile was very, very encouraging. Do you think it's because of the reversibility of the BTK inhibition?
That's an interesting question. I think that maintaining intense pressure on BTK is probably important for efficacy. So I'm not sure that the reversibility is helping, except if there are some minor off targets where the drug is much less potent, then maybe the reversibility is helping. But Loxo is the most specific BTK inhibitor of any of them out there, covalent or non-covalent. It's really quite specific. So I think that that is probably substantially contributing to what appears to be the very excellent toxicity profile.